Good afternoon, and welcome to HealthSystemCIO.com's All-Star Panel, Mastering Transition, Supporting Yesterday's EHR While Launching Today's, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by Encore, a Quintiles company. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat going on, hosted by our Managing Editor and Director of Social Media, Kate Gamble. If you want to participate, go ahead and open a separate browser on your computer or on your phone and use the hashtag HSCIO chat. To view the tweet chat, you can do so in the Media Viewer panel on the right-hand side of your screen. You can just click the arrow to open and close it. Other WebEx panels that will come into play today are the polling panel and the Q&A panel. Q&A panel you use to submit your questions. You can do that at any time. Type them into the lower right-hand corner of the screen and keep the default set to all panelists. And you can download the deck by using the URL on your screen. Just so you see how we're going to spend our time today, we're going to go about 45 to 50 minutes. First, we're going to have our panel discussion with Cara Babachicos, CIO and Corporate Director, Community Hospitals and Post-Acute Care with Partners Healthcare, Chuck Podesta, CIO at UC Irvine Health, and Tom Niehaus, President and COO with Encore, a Quintiles company. So now we're going to jump right into our conversation. Cara, you want to start by giving us an overview of your organization and your role at Partners?
Sure. So Partners Healthcare is based in Boston. We are the second largest employer in Boston area, 60,000 employees, 2 academic medical centers you might be familiar with, Mass General and the Brigham, as well as several community hospitals and post-acute sites. The post-acute sites are Spalding Rehab, McLean, mental health facility, as well as Partners Healthcare at Home. And we also have a very large physician network. So, and we are in the midst of a major information system install across all of our sites. Very good. Chuck?
Yes, thanks, Anthony. This is Chuck Podesta. I'm the CIO of UC Irvine Health. We're an academic medical center located in Southern California, Orange, California. We also have the School of Medicine on the Irvine campus. I'm in charge of the medical center, also the School of Medicine and Research for UC Irvine Health. UC Irvine Health is part of the UC University of California system. So there's 5 medical centers: UC Davis, UCLA, UC San Francisco, UC San Diego, and us, and we collaborate very closely. We're actually in a large implementation as well. We're switching EHRs, and we're actually using UC San Diego as our host. So it's will be 2 academic medical centers coming together on the same instance, and we're also we've also implemented a legacy support strategy as well to support the implementation.
Very good, Tom.
Sure, thanks, Anthony. So Encore Health Resources is a healthcare IT consultancy. We were founded in Houston, but we're currently headquartered out of Raleigh, but our workforce is primarily remote. We've been around as Encore since about 2009, but you know, our leadership and most of our folks have been in this business for their whole career. We're focused, really, I would mention a couple of areas. Advisory services and solutions is a big focus of ours. Everything from IT strategy through, you know, analytics and planning and so on. Implementation-related services, including training and go live. And then application management, which is one of the things we're going to talk about today. A couple of things I would mention about us that maybe makes us a little different. We're known for our clinical and operational expertise, as about 77% of our folks, you know, are clinicians or have some type of graduate management degree, and about 87% of our staff have healthcare operations experience. And then finally, we're known for a solutions orientation in bringing proprietary tools, which include data mapping tools, quality reporting and analytics tools, and then proprietary methodologies for our consulting. And most recently, I guess about 2 years ago, we're now part of Quintiles. Many of you may not know about Quintiles, but it's the world's largest clinical research organization. They're known for their scientific therapeutic expertise and their quantitative and analytic expertise as well. So that's a little bit about Encore.
Very good. Thank you, Tom. All right. Let's start with you on this, Chuck. Talk about your EHR migration journey or journeys. I think you've done it a few times. What are some of the challenges and the lessons learned that come to mind?
Well, the recent one, I've been at UC Irvine for 2 years now, and as soon as I got here, we realized that we were not on the right system for, to support the strategies that we had going forward in the future, population health and those things. So we actually started a planning process, and it was fairly unique because, because the other 4 UCs were all on the same system and we were the only one that was not, we looked at ourselves first to see if we could be a partner with one of the UCs and went through that kind of scorecarding process. And then once we realized, yes, we could probably partner with somebody, then we had to go through a process of picking the best UC medical center to work with. And that all took a while to do, and it was a little bit different than just working directly with the vendor. And we settled on UC San Diego and went through a large, big due diligence process with them, and kicked off the project about 2 months ago, and been moving forward. I think the challenges we had here were just getting everybody's mind around having another UC host us and some of the guiding principles that you have to have in place around the build and changing workflows versus the build and some of the things that clinicians get a little bit worried about. But we've been able to put some really cool guiding principles in place, looking at best practices of both organizations and across the UC, and adopting those so that UC San Diego will change their build to adopt the best practice that we may have or UCLA may have versus just us taking the UC San Diego build as is. So we've done some things there that I think have softened the perception of that we're just taking the UC San Diego system. So that was probably the biggest challenge to get over.
2 months, and how's it going so far?
Going great. We're actually upgrading the ambulatory systems. We've got a team embedded there at UC San Diego to do that. We're doing it for a couple of reasons. One is we want to refresh the build. They've been live for over 10 years. And then we want our team to learn the build so that they can bring that build back and we can do the gap analysis. But UC San Diego gets the benefit of getting a refreshed build for their clinic. So it's really showing a collaboration between the 2 organizations. It's been a big hit. They're also opening a 250-bed hospital this fall, so we've got a team embedded on the inpatient side too, and we'll be helping them with go-live support and training and those sorts of things. So it's been a very different type of implementation. We also have a group embedded that's actually creating a diary basically. We just feel that this is such a unique project that we're going to want to tell people about it at the end for sure.
Very good. Cara, as you mentioned, one of the biggest installs in the country going on at Partners. So talk a little bit about your journey and some of the things you've learned.
So it's a 5-year implementation plan, and we're about 60 to 70% through with a lot of the smaller sites coming in Wave 3, which will go live in January. They're still not small sites in the whole big scheme of things, but smaller in comparison to the sites that have gone, or families that have gone live. I'd say that one of the things that my teams have focused on is at the site you have the central groups that are implementing the system along with the site folks, and to balance how we will be installing the system and the handoff and the exchange of information to people who reside at the sites and how they will help support the system once we're live, and trying to ensure that there's mutual success on both ends, both on implementation and ongoing support. Because in order for us to get through a 5-year plan and install at so many sites, you have to be able to quickly implement and then leave behind a strong team to help support it in the end. And so I think we've been learning a lot as we go through this process about how we need to keep our, what we're calling clinical business analysts at the sites, how we need to train and educate them, how we need to keep them involved in the process, not just at the end, but all throughout the process to increase their understanding of the system, as well as trying to fine-tune, what type of training do they go to and how deep do they need to get into their expertise, and how they support a portfolio of applications versus one application in its entirety. So there's a lot of handoffs we have across our sites, and we have to rely a lot on our task management system and other things in order to make it successful. We also will have a fair amount of stay-behind legacy applications, and so related to the legacy applications, we have to ensure that we have an interface engine that will work with them, and then also understand the downstream impact. So I would say conversion, the support, the training, the legacy apps, our ongoing need to retire systems that will no longer be our primary EHRs, but to understand that we have a request of information that we'll need to be able to furnish records for up to 20 years, and a strategy around how to do that. As well as we're learning a lot about governance and prioritization. It's already hard enough across the site to say no and to deal with the ongoing demand. How do you do it when everyone's coming together and asking for a lot of different projects, when there's a finite group of resources able to optimize the system, if you will? And so we're learning a lot about that, and learning a lot about working with one system. There's pros and cons. It's great that we no longer will be a patchwork quilt in our EHR, but you also have to understand there's new vulnerability. When that system goes down, it's the EHR for everyone, and understand how you negotiate downtimes and upgrades and all the things along the way. So it's been a great learning process, and I think people are generally bought into it, and I think we'll be very successful, and we're making some major milestones along the way, but it's been a journey, and it's still going on.
Yeah,
I don't know if that helps kind of summarize.
And we'll talk more about stay-behind legacy apps and things like that. I just want to ask you a follow-up question about the need to retire. You used that phrase, the need to retire these things. So you want to have that transition period. You want to have those legacy apps available for as long as they need to be, but eventually you want that stuff to go away, right?
Well, in Massachusetts, we're required for adults to retain the record for at least 20 years. So we have to make sure that if a request of information comes in from an attorney's office, or patient's family, or another PCP, or whomever, that we're able to furnish different records that are required, and as well as the audit trail and all the security components that go along with it. So for us, we have to be cognizant of our strategy. When we get into children, it's even a longer period of time, so we have to maintain their records a certain period of time until they're 18, and then go into the additional years plus that. So some of these records we're going to be keeping around for a very long period of time. And the fact that we went to meaningful use in the different stages on our legacy systems are now an interesting predicament, because we have to be able to extract electronic data in a usable format. We're no longer a file-based system, so which a lot of our sites probably are in the same boat. So we have to think thoughtful about how we do this in an effective way, and we're trying to use somewhat similar strategies where we can to get economies of scale and general best practices.
That's good. Very good. All right, Tom, let's start with you on this one. Do you think folks preparing to select a new EMR underestimate the challenge of transitioning off the one they are currently using? What is the biggest danger in underestimating this particular challenge?
First off, I think folks are always aware that that's out there, and they want to make sure they take good care of the users of those systems, et cetera. But I do see folks that make some mistakes, and one is real simple. Sometimes they neglect to budget for whether it's the backfill, if you're going to hire a third party to do it, or the distraction and lack of focus if you're going to expect your staff to kind of do two jobs. So having a plan, including the financial aspect of that, is huge. And then the other piece that Cara touched on a bit is thinking that through all the way through the retention issues. So it doesn't, that issue doesn't go away once you go live on that new system. You've got to continue to, in some cases run down AR. There are other requirements to retain information and data. And often you have to be able to bring up that system and access it, to work an issue or something like that, or have an alternative anyway. So the idea is to have a plan starting with a budget that accounts for it, but you have to look at it holistically, not just during an implementation or a major upgrade, but all the way through the full requirements to retain that information.
You mentioned, Tom, the idea of distraction if you're expecting your team to be taking a new system live while supporting the old system. Can you talk a little bit more about that? I know Chuck touched on it in some emails we were exchanging before our webinar, so I'd like you to touch on it, and then Chuck, if you want to jump in.
Sure.
Yeah, well, first off, it's very, very difficult, and we've talked about, Epic sites here and a couple of examples. In the Epic world, it's almost become best practice. It's to have someone else come in and focus on maintaining the legacy applications, and for good reason. Epic themselves really encourages sites to have their staff certified and fully committed to these implementation projects, and they're complex initiatives, and you've got a timeline that you want to hit, and having folks being able to fully focus on the task at hand is critical. So I think it's very, very difficult, if not impossible, for folks to really do an effective job as part of an implementation initiative and providing production support, because the production support, even though most folks take kind of a keep the lights on mentality, there are still business is going on. You're still maybe acquiring physicians. You've got routine maintenance and tasks. You got regulatory issues to deal with. All the complexity of running a production system is still there. So very, very difficult to do both. And so I think, as I said, it's kind of become the best practice because of the focus. I think having folks focus on the implementation yields better results, and frankly is a lower cost. Perhaps the alternative might be to hire consultants to help with the implementation. Generally speaking, it's less expensive, more cost effective to use somebody to do the support of the legacy applications as opposed to somebody providing implementation services.
Chuck?
Yeah, so at UC Irvine, what we did here is we knew we were going to get started with our implementation sometime in the June timeframe. So we did an RFP for legacy support back in March, and knowing that we needed to get somebody in and give them a good couple of months to get ramped up with our legacy applications. And that's worked great. We ended up picking a company that had an overseas operation, and so we were able to mix the support between onshore and offshore, and actually, as Tom said, we're actually saving money doing that, and it's also freed up I think we freed up about 75 people on the applications team over those 60 to 90 days, and we started with certification in May and June. We were able to get a lot of our people into the May-June cycle, and then also into the August cycle for certification, and we have people coming out with their base certifications, and we're embedding them into the project right away. And what we're seeing for benefits on this is that I would say the biggest one is just the morale of the team. Once you start announcing that you're moving to a new EHR, you can imagine the staff is sitting there saying, what's my future going to be? What does that look like? And this is a way that you can move them into that future very quickly and get them focused on the future and get them out of the past. And that's worked extremely well, and it shows that you're really supporting your employees and your people. The second thing we're seeing is that by embedding them in the project, and Tom mentioned this, is that we're going to be starting to see a lessening of the need for consultants over time. we feel by about January, February, we'll have a pretty core group that's pretty proficient on the systems, and they'll start to replace some of the consultants that we have, so that we'll, I think we have by February or March, we'll have more of our team on the project than we will consultants going forward. And we go live in November of 2017, so it's a good 7-8 months before we go live that we'll be embedding more of our people than consultants. So really taking ownership of the system and saving money at the same time. And the other nice thing about it on the financial side, when you bring in a legacy support, you pay for that out of OPEX, and you move your people over to CAPEX. So if you're moving more people over to CAPEX than what the legacy support is costing in OPEX, you actually save money on the operating side, which hits the bottom line that particular year. So that's been a huge benefit to us as well in saving every dollar.
Excellent. Cara, thoughts on underestimating this particular challenge of going live on a system while maintaining your legacy apps? Do you think a lot of people are underestimating what it takes?
Oh, I mean, it's a lot of work to go live on the systems, yeah. I mean, I would say that at Partners, we unfortunately didn't follow the model that you're describing of bringing a lot of the IT resources in and then backfilling them, allowing them to run the project. I think it's a great model, but it's not the one we necessarily used. So we have some of the work we're doing right now with trying to get the site folks feeling good about what their roles are going to be and how to get them engaged a little bit later in the process. And there's definitely something to be said about engaging them sooner and using the internal intellect rather than outsourcing it. But that being said, we're on the road we're on, and there is over a 5-year span, and with the sites all having different legacy systems, there are probably other challenges there that we also had to undertake. But just trying to get people lockstep and barrel in terms of all trying to work on the same projects and understanding the site implications and the downstream systems, I think is part of our ongoing challenge.
Very good. You were talking quite a bit about costs, Chuck, and different ways to manage the costs. Any additional thoughts there?
Well, just when you use, depending on the EHR you're coming off of, if you can use a managed services group that has overseas operations, the hourly price points are unbelievable. So about 20 to 25% of our legacy support is coming from overseas. And that's what's allowing us to actually, support these systems and save money versus what we would have been paying our staff to support these systems, because we have the benefit structures of the UC system and that sort of thing to deal with. So it was a lot more costly for our own people to support these systems than having a legacy support company come in and do those for us with that overseas operations. And that's what we're saving. We're seeing about, I would say, about a 30 to 35% savings on our monthly run rate for those support applications. The other thing we're trying to do as well is we adjust the number of people that we have from the support company based on what we feel the need is. We're probably staffed right now at the highest level we're going to be because we still have requests coming in. We still have to do work on those legacy systems. But as we get closer to go live, we'll start to ratchet that down, put more freezes on, and then we'll start to, those numbers on the legacy support side will start to come down. So again, you'll get the savings associated with the drop in those number of people that we have supporting those applications as you get closer to go live. And with the legacy support strategy in a company like that, you can control that a lot better. You can imagine if they were your own FTEs, how difficult that is to move some but not all, and try to figure out when you actually pull the trigger on moving them, to the new environment and getting them trained up. This makes it a lot easier, and we still deal with it as one big project, but we have separate PMOs for each and separate leaders for the Epic implementation versus the legacy support. But they work, very closely together to make sure that we're not dropping the ball.
Very good. Okay, we're going to have put out an audience poll really quick, which should be open now. Assuming you have been or are currently going through an EMR transition, was the process more difficult than you anticipated? And we're specifically referring to keeping those legacy systems up and running. Was it more difficult than you anticipated? Or if you have knowledge of a project, worked on it, we're not looking to be too scientific, just give us your thoughts. So we will get back to that in a minute. Let's talk a little bit more about compliance. Tom, and Cara touched on that 20-year issue. Are there issues of compliance, records retention, and availability that must be adhered to when setting applications? We know the answer is yes. And how are they best managed? Tom?
Well, like anything else, the key is to plan early for those things. You know, as Cara illustrated, there are different rules and regulations depending on where you are in the country. But there are ways to deal with that. You know, there are a number of companies, for instance, that specialize in taking data, you know, from some of these legacy applications and converting it over onto their servers, where they have, you know, the ability to bring up a fairly simple access method for you to access that information and allow you to retire the original system and even the hardware that it runs on and get it off of your floor. But if you look at it early, you know, in the process, you got issues to think about and consider, including, do you want to convert it to your new HR? Do you want to take some of that data and bring it over as part of the conversion? And then all the various options for archiving. And you got to think about workflow as well. You know, when these systems are gone, are there, you know, other systems that are impacted? You know, how does that information get used? Who uses it? That kind of thing. So the key is to plan early and to make sure you've allowed adequate time to kind of get your plan in order and executed.
Very good. Chuck, any more thoughts on compliance?
Yeah, sure. Yeah, we've luckily here, actually this is our third EHR. So we had the TDS system. I don't know for anybody that's on the webinar that goes that far back, but so we had to do archiving of that. We have a pretty strong analytics group here with a pretty robust Hadoop data warehouse, and we've been moving data from the EHR and all of our systems basically into that for many, many years. So it's, from an archiving aspect, we've got that covered. We are still working through conversion, though. As Tom mentioned, we do want to move a good portion of the data, you know, into the new system, and we're working through that right now. But we already have a link to our current legacy EHR to our analytics engine for the TDS data that's over 20 years old. So we're going to pretty much follow that same type of approach using our analytics for read-only type of process. We've looked at some of the archiving solutions out there, and they run the gamut, but I think it's still an immature space. I haven't really run across anything that's easy to work with and easy to use at this point. So luckily we're in pretty good shape with what we already had.
Okay, very good. Let's share the poll results. Cara, we see that 93%, and I'm guessing this number doesn't surprise you, said the process was more difficult than they had anticipated. What are your thoughts on that number?
If our life was merely just putting the software system in and walking away, it would be so much easier. It would be a lot easier than it is. So I think the software side of putting a system in is the easy part. It's the getting the people part and getting people trained and understanding the process and understanding how it maps to and compares to the previous process. And there's a lot that happens that takes it to that extra higher level that makes things a lot more complicated. So I am not at all surprised that, you know, an EMR transition, as you get deeper and deeper into it, you start to realize it's a lot more complicated than you ever thought it would be. I would also say that a lot of the vendors in the conversion strategy try to steer away from putting a lot of old data into, or legacy data into their system for mapping reasons, and if you're changing the EMPI and the master patient index is looking a little different, or if you're merging things together differently, things don't necessarily compute, so that adds another layer of confusion. Not to mention you're data interface engines and how you manage data and interface engines with your various vendors and what they can accept and what has to be done differently in extract process and how research and other departments rely on extracts and the importance of that in reporting. Sometimes people generally, and one of the things I've seen, as we all probably have throughout our career, every time you put in a system, they reproduce the reports that you had in the old system. Later to find out that half the people aren't using them anyways, and no one really did an integrity check to ensure that it really works. So, that report, understanding your report data and what your essential metrics are and what you're going to be using to measure yourself in the new system and what the new, I guess you will, lexicon or, the mapping of the dictionaries and how everything kind of maps out in terms of reporting and importance for the CFO and others is also really important and something that comes up a lot as you go live with various systems in terms of how you make people happy with giving them data. So, I mean, this could be a whole discussion in and of itself, but it's not surprising that it's a lot more complicated once you start getting into it.
Very good. Chuck, let's go to you on this, and it sounds like the answer is definitely a yes. Is this type of work one in which outside help is valuable?
Yeah, absolutely. But I think it's a balance. We're balancing the EPIC implementation and the number of consultants that we're using there with the legacy support consultants that we're using there. So they work hand in hand, and we have this big grid that we're looking at, the number of our resources, the number of UCSD resources we have in the project, the number of consultants, number of the vendor EPIC consultants, and then the number of legacy support people. So we have this whole grid that we look at and the ebb and flow on a monthly basis of how many people fit in one of those categories. And really the goal is to have our legacy support company really take over as much, 80, 90, close to 100% as we can on the legacy support, get our people over to the new environment, so that then we can reduce the need of the consultants going forward on the EPIC implementation. So even though they're separate projects, they work hand in hand with each other. And if you're paying, the thing I like about it is you're paying less money than you were with your own people on the legacy support model. Then you're using those people to take over the more expensive consultants on the EPIC side as you implement. It's a win-win when you look at the financial model. And again, the legacy support is OpEx, so if that's less than what you were paying your own people, you're moving your people to CapEx, you're saving money on the OpEx side as well, so that's a bonus. The last thing, again, as I mentioned before, is the morale of your people. I can't tell you how, when we have our all-hands meetings and how excited people are, then they're not talking about, where do I fit or what's the future look like. They already know. They've been to EPIC. They're being certified. They get it. And so we've got our best and brightest, moving forward and very early into the project. So that's another win.
Very good. Tom, why don't you just sort of break down the application management solutions for us, if you want to add any additional detail to what we've touched on. So what are they, the basic definition, why are they sort of becoming more popular now, and then some follow-up questions. Is it an all-or-nothing proposal? Are there ways to make this, to segment the work that makes sense? And is the AMS approach better than a backfill or hourly rate approach?
Yeah, so first off, I don't know that there's any one single definition, but obviously application management is just that. It's managing the suite of applications that you have, either with internal or external resources. I don't think it matters. It gets into the whole ITIL framework a little bit, but it's that layer that is focused on break-fix, routine maintenance, enhancement requests, and support of applications. What's driving it? First off, that solution's been around for 20 years. I think I was involved in the first one I did back in like 1994, and at that time it was an IDX implementation. So the solution's been around a long time. I think it's become much more prevalent, as I said, in part because of EPIC's approach to implementation. They place a premium on having your organization fully commit and ideally having resources, literally leave and go to Wisconsin to be certified, and they, offer discounts for organizations that utilize their staff, certified staff, to participate in implementation. So it, in a way, has created, as I said, what's almost become best practice in the Epic world. But it's really gone beyond that. I mean, those are all examples of legacy application management where you've got some lame duck applications that are going to go away. But I think what we're starting to see emerge in the marketplace today is something that's more comprehensive. One of the real challenges out there today is an area that's called portfolio management, or application portfolio management. And so it's the idea of looking at all of your applications across your enterprise and trying to figure out, you've got some that are clearly strategic and are going to be around for the long haul and require ongoing optimization and upgrades. And a lot of organizations are looking at those and figuring that that's where they want to spend their time. They want to build, great expertise and have teams that are capable of optimizing those solutions for many years to come. So when you look at all of your applications, though, you have others that maybe have been around a while, but maybe they're not going away. Maybe they're ERP applications. Maybe there are other applications, that are a part of your portfolio, and maybe you want to look at what's the best way to support those. Is it with my own staff? Is it with some third party? And as Chuck has alluded to, I think there are different ways to address that with different types of resources. And you'll frequently see a blend, some on-site support from a third party, some remote but onshore support from a third party, and then, of course, the lowest cost of all is remote offshore. And blending those capabilities and bringing those to bear on applications that are either going away in the short term or maybe not going away, you're just looking for an effective way to manage those and maybe allow your team to focus on those areas you think are most critical. So I think that's a big need today. We're starting to see that emerge quite a bit. And it fits nicely, with the whole idea of your workforce management as well. It's combining the two thoughts, how to manage your portfolio of applications and what's the best way for you to staff your IT organization. And there are some solutions out there maybe to help you do that, and as Chuck indicated, frequently cheaper than you can do it yourself. You asked, is it an all or nothing proposition? And the answer is no. There are ways to achieve having a third party manage a portion of a set of applications, a series of applications, while you've got your staff focus on others. Where it gets a little complicated is frequently these arrangements include service level agreements, and where you're mixing the team between the client and the third-party vendor, that can get a little bit tricky. But there is a lot of flexibility there, I think, in how to engage and how to divvy up the work. And what you're trying to do is take advantage, again, of focusing up your team on those things that are most critical and strategic to you, and then trying to figure out what's the best way to manage the rest of the applications. And you may have different drivers. It may be cost. It may be quality. You may want to actually, have somebody come in from the outside and really focus on reducing your backlog of tickets or something like that. So I think there's literally limitless combinations and different ways to utilize that type of service if you're interested.
Very good. All right. I just want to remind our audience that if you have any questions, go ahead and type them into the Q&A box, the lower right-hand corner of the screen, and leave the default set to all panelists, and we will take a look at those. So we're going to open Our second and final poll, are you considering outside help such as application management services to navigate your EMR transitions? It's an anonymous poll, so don't worry about having your identity revealed. Just go ahead and answer if getting outside help that we've discussed today is something you would look at. Sounds like everyone thinks it might be something to consider. Let me go with Chuck on this one. If leveraging AMS, how important is flexibility when you make a long-term agreement, and what's the best way to monitor vendor performance and quality during the engagement?
Yeah, so what we did here is we actually did a fixed fee model, and it was based on an estimate of the number of people that would be both on-site, remote, onshore, and then offshore, and there was a blend there. And so we track that on a monthly basis. And again, we also have SLAs, as Tom mentioned. So we look at the SLA performance along with the number of people. And what we were able to work out, and it's made it really flexible, is that if, for example, in 1 month, we have planned to have 30 people in a total between all three categories from the legacy support company, and they do the work, they get the work done and meet the SLAs for 27 people. We actually then get credited for the 3 people because, again, we're under a fixed price, and you start to build up a little bit some credits along the way, depending on how you manage this, and you can use those credits again against future invoicing. So we work very closely together. We have a person here that's on our that's a UC Irvine employee, director level person that's engaged, that is kind of the project director on the legacy support. And so he, even though there's leadership within the legacy support team from the outside company, he runs it. So he's looking at the SLAs, he's looking at the number of people, and he has control over how many people we use against those SLAs, and he monitors both those together. So we put that into the contract so that we're able to, even though we think we need 30 people, if we can do it with 25, we can save a lot of money. So that's the goal of having that flexibility within the contract, but also using a fixed fee so that at least what the conservative estimate of the most that you're going to pay at the end of that particular project before you even start.
Very good. All right. We're going to look at our poll really quickly and share those results. We see about 50-50 in terms of folks looking at it versus not looking at it. But it sounds like it's something worthy of consideration. So let me go, Cara, to you for the next question. And, you touched on the idea of sort of corporate going in, doing the implementation, and then having to go back out to do the next implementation in the health system at another site, and making sure you're leaving those folks who are going to live with the situation in good shape. Maybe some train-the-trainer type stuff sounded like you were alluding to. But any more thoughts on managing user expectations, those who just love the old system and, don't want to stop using it?
Well, I think to get them involved in a lot of the workflow discussions early and often, are often the best approach to kind of getting them to understand how the new system's going to work and trying to adjust accordingly with their practices at the site. I think the other thing when you're trying to sunset the application is the reliance on, well, I still need to get the old data that's in the legacy system. So how are you going to still provide me with the last discharge summaries for the patient? Or how can I see notes that I didn't get converted into Epic, or I didn't put into a repository somewhere? And so how do you manage some of that stuff, and how do you manage that health information management team and their expectations around what they should be able to get out of the sunsetting applications? I think that's one of our challenges right now, is they want everything that was there, and how do you give them the right data elements, the right reports, without boiling the ocean, if you will, because it can be sunsetting the application formally sunsetting it, turning off the maintenance, can be as much of an upward climb as it is trying to implement some of the EHR systems. So I think there's a couple of things. One is managing, if you're managing the new and the old, I mean, some of it is they just have to get over it. It's not going to be the same system, you know, and
right.
You try to extend the workflows, you try to train them, you try to give them the policies and procedures, and then after that, there's not much more you can do. But in terms of sunsetting the old system and kind of understanding what they have to get out of it before they can turn it off is another issue that we're constantly working to address, so that we can not be paying maintenance costs to our legacy system vendor that we're sunsetting, while at the same time paying system costs for the new system.
Right, right. Definitely. All right, we have a question from the audience. Let's start with you, Chuck. We'd like to hear more about best practices for governance in moving towards more centralized decision-making around clinically related EHR content, documentation, templates, order sets, et cetera, workflows, et cetera.
Yeah, so, and then Cara can certainly chime in on this. She's been through the wars on this one, but we have an IT governance steering committee, but underneath that we then have the kind of the work group governance aspects of it. So we've got a clinical group, revenue cycle group, and various other ERP groups, and they deal within their own areas. They're all multidisciplinary teams, and so a lot of the priorities for changes or enhancements or decisions on build and things like that come through these particular multidisciplinary groups. And again, it's a mix of the IT resources and the user community, the customers using the system. You know, certainly physicians are involved in that. And we have a formal process as a charter. There's, ways they, bring these requests forward, how they're vetted is all documented. We even have scoring grids and things like that associated with how these things get in. But you have to, I mean, we've had that all set up when I first got here, actually put that in place knowing that we would be moving, to a new EHR. So, again, I guess my recommendation would be just to make sure if you don't have strong IT governance with your current EHR, you better beef that up before you move to a new one.
Cara, what are your thoughts around the question? I can reread it if you like.
Yeah, if you want to reread it just to make sure I address it appropriately.
Sure. Would like to hear more about best practices for governance in moving towards more centralized decision-making around clinically related EHR content, such as documentation templates, order sets, et cetera.
Okay. So a couple of things. So best practices on governance in general. So maybe just to explain a little bit about our model. So if you can kind of imagine it, every site had their own set of governance, right? So if I wanted something done in my legacy vendor product, my major EHR at site A, it was about me and my IT department, for the most part, working with the site leadership to determine what needed to be done, and then resources needed to do it and how it fit in with other priorities. Now imagine that you've taken that and said, now we all use the same system. So you have the site A that might want something different than what site B wants, which is different than what site C wants. So we've tried to come up with a couple of things. We've tried to come up with site governance to at least look at what are the major priorities across sites, and then across care areas or business practices come up with commonality. So, the clinical documentation perspective, get people that are across all of the different sites to come together that then talk about what seems to be the site priority and how it can get addressed in one common solution. Do we have one order set? Absolutely not. Have we tried to, streamline them where possible and eliminate a lot of needless ones, or, look at redundant ones? Absolutely, we've done that. But so I'd say it's still a work in progress. We're still working on that whole process and trying to refine it. But we have site governance. We have governance based on the common areas of documentation. I mean, there's a lot of governance teams. I can't even begin to list them all. And then we have work groups under that. And then we have site submitters, who are the people that help fill out the demand forms to help scope out the requirements so that we understand what's being asked and answered. And then we've tried to build in, and we've been doing this for years at different sites in different ways, but we've tried to do a modeling of weighted importance based on cost, quality, clinical outcomes, and trying to understand, like, how do things really compare to one another on a standard scale. And we're still refining. We keep refining as time goes on and making sure we have the right people at the table. But so it's definitely an ongoing process, and we have a lot of layers in that, trying to work out the right cadence, if you will, on how we're going to prioritize that, those changes across many sites with many different resource challenges and different levels of need.
So there's no lack of governance, right, Cara?
Oh, no lack of governance, no lack of trying.
There you go.
Yeah.
Okay, great. Just real quick, we haven't heard from Tom in a while. Tom, I just want to know if you had any final thoughts, advice for the audience, a takeaway message, because we're going to wrap up soon.
Yeah, just one quick one. We've talked about SLAs quite a bit and how to govern one of these contracts. I've heard some good info from Chuck on that. But one thing I would advise folks, if you think you're going to do application management with a third party, one thing you ought to do is make sure you have good SLAs in place today, that you've established a baseline. A lot of folks, most everybody has a ticket system, but we frequently find that folks have not really gotten good SLA reporting in place, and then you got to take a couple of months and establish baselines and things like that. So my advice would be to figure out, using your existing ticketing system, how to get some good SLAs in place and be able to show some baseline data, so that when you bring in your third-party vendor, you've got a baseline to start with, and then you can track performance over time and see how you're doing. And as Chuck said, you kind of can taper off or augment the support as needed based on demand, because over time, as you get closer to the go live, the number of enhancement requests and so on tend to go down, and you're going to want to roll off that staff. So having a good SLA program in place prior to the contract, I think, is a really good idea.
Excellent. Well, that's about all we had time for today. I want to ask our audience, as you close out your window today, you'll see a post-event survey pop up. If you could just take a few seconds to answer that, we'd appreciate it. I want to thank our panel, Cara, Babachicos, Chuck Podesta, and Tom Niehaus, and definitely thank Encore for sponsoring the event today and making it possible. You'll receive an email when our archive recording has been posted to our YouTube channel, so you can go ahead and enjoy that. For those of you who hold the CHIME CHCIO certification, attending our events get you 1 CEU, so let CHIME know you were here, and if you've asked us to do so, we will. Sponsorship opportunities, you can contact Nancy Wilcox, and if you need a certificate of attendance for another CEU program, you can use the final slide in this deck, and of course go to our website to view our upcoming schedule. So once again, I want to thank Cara, Chuck, Tom, Encore, and our attendees. Everybody have a wonderful day. Thank you.